A small topic. I was very, very happy that pulmonary valve was not inside in congenital heart disease in 8 minutes. So I'm only covering 3 valves in the human body. So it's a very, very narrow topic today. These are my disclosures for this topic. And also on the cost issue, I cannot compete at the moment. But we should always remember that also pacemaker costs in the past has been $8,000 and is now below 1,000, and the devices cost you, even from Medtronic, etc., in Europe and Germany, only 400 if you buy them as a hospital. So there is hope, and we see the same with stents and drug-eluting stents. So there is a need for valvular interventions, and despite the treatment with guideline-directed medical therapy, the happy 4, as I call them, heart failure, morbidity, and mortality, we've seen this, remains high. And there are acute and chronic heart failures that have a strong interaction with valvular heart disease, and valvular intervention has an impact inside and outside the heart on pre- and afterload conditions. And they, as was mentioned by Marat already, they can also influence guideline-directed medical therapy doses and perception, and as well as compliance. And it also influences cardiac output, a topic that we have not raised enough emphasis on, because it's not the ejection fraction, it's the cardiac output and cardiac index that makes the patient live better and perform better. Valvular treatment, though, has disease and outcome modifying effects on functional parameters. This is very well demonstrated. Quality of life, as mentioned before, where the FDA in 2021 approved the Kansas score, and also in selected subgroups on survival. So this is a very recent publication, just 3 weeks ago, from a position paper from the interventional cardiologists in Europe and the heart failure groups. And you can see that the notion between chronic valvular heart disease and heart failure, as well as acute valvular heart disease and heart failure, has been mentioned. And this is a type of position paper preview on the upcoming guidelines that we'll see in August, September this year at the level of the European Society of Cardiology. We know, and we mentioned this before, that secondary MR is included in the guidelines. Aortic stenosis is with a 2A, but also in Europe for a selected group outside the tier possibility with a 2B recommendation. So also this covers replacement and other situations, because TEER is not for everybody. We also need alternative devices and valvular devices to treat everybody. There are randomized trials, and these trials, patients up to 90 years of age were included. And this is the Class 2D trial that looked into acute primary disease and heart failure. And you see that the outcomes were very good. And I'm not focusing on the very good reduction to MR2+, which was achieved above 94% in both groups. And this was the primary endpoint. But also over the range of 6 months, actually 1+ MR was achieved in the range of about 80%, and I'll show you newer data that's even higher. You see that there may be sometimes modest improvements in 6-minute walk, and you can see the delta here is between 23, which equals to the delta actually of the Triluminate trial, and up to 41, and we have isolated single-arm trials where we see improvements up to 75 meters, but they're occasional and they depend on patient selection. What is more important, that the educated freedom from mortality and also the remodeling has been shown, something we haven't seen in the co-op trial, because those patients were already relatively far down the road. And Marty mentioned this, the freedom from hospitalization and death was only 73%. So this is something we can still improve when we see the residual burden in those patients. Just this Tuesday, actually, the 1,160 patients of Expand G4 have been published in JACC Intervention, and you can see that this is an extremely safe procedure. On the right lower side, you see the 30-day mortality, and you see the experience levels. If you look back to the first TRAMI registry, we had a mortality of 4.5% at 30 days. In the STS-TVT registry in 2017, we looked into, even at primary disease, into a relatively high 30-day mortality. But look now to the right side, the EXPAND being transatlantic in the US and Europe, already going down to 2.3, and if even more experience and the higher rates of secondary MR, which is non-beneficial actually, we see a further drop in 30-day mortality to 1.3. So these situations are very, very safe. And you also see that we range to 83 to 89% now in the latest device iterations to MR1+, which is seen as a success or optimal result, not like the group that is beyond that, 11%, that still do not receive optimal results, and where we have to think, is this the right device for these patient selection groups? Looking back into the Seibel publication in Circulation, you see that the effects of guideline-directed medical therapy and devices are the same, but the numbers at risk are different. While 70% of the patients in GDMT only remain in the severe and more than severe, moderate to severe and severe group, actually this group is very, very low. It's below 7% in the device group. So you see that the treatment effect is added by adding not only the Fantastic 3 at that time, now the Fantastic 4, but also a parallel treatment by devices. It keeps you in the range of 0 or 1 plus MR, and this group is getting larger and larger, and this depends on the interventional capabilities. We already heard about the landmark trial, and I'll very quickly go into that. ACC this year in March, the 5-year results have been published, and with exceptional results. Look at the hazard ratio. This is 0.53 for device therapy in addition to guideline-directed medical therapy, even though this can be further improved. But we also have to remember, Marty, that these patients were at the index situations in mean 75 years. So what's the life expectancy at 5 years after that? This is exceeding, they're at 80 years, and the average healthy person has life expectancy as a male, like in this study, and 66% ischemic disease. That's well below the 78 years of age range. So actually, I think these results are still okay. And you can see that we've seen here actually a 30% reduction also in all-cause mortality, which is the hardest endpoint that we can ever have, which is not influenced too much on other situations. And there have been crossovers after 2 years, which can dilute actually the results, but you can see that these patients did almost as well, even though some of them died before, do almost as well as the initial group being treated. So there is perhaps a not too late, but we may have to come earlier for a lot of those trials in order to prevent deaths. And what is very reassuring, and which was questioned by heart surgeons, is that the results are relatively stable over 5 years. So we see reductions are stable, and we can show this in several publications. This is a European registry, 1,640 patients. And you see that 40% of the patients could be up-titrated after the device therapy. So they tolerated higher doses because their blood pressure rose by 10 to 20 millimeters of mercury. So guideline-directed medical therapy, or the Fantastic 4, could be increased in their up-titration. And this was outcome relevant. These patients did better than those who were capped on the same medication dose. So we can also see devices as an enabler for a better guideline-directed medical therapy. In a smaller group, like the CLASS study, it's just to show you that this is a class effect. This is the Pascal system. We have follow-ups for 3 years. You see also a phenomenally safe procedure. You see the differences between DMR, cardiovascular mortality, 5% if you have a prolapse, 18.8% if you have functional or ischemic disease. So it's a different entity, and we have to differentiate those. But in both groups, we saw remodeling, not only on the DMR side, but this is one of the first reports over 3 years after the Pascal treatment, actually to have positive remodeling of the ventricles. And I think this is very important. We also see this in other situations. This is single arm only, but you see a reduction in the annualized, and this is important. Heart failure hospitalizations, it's not the time to the first hospitalization, it's the load of hospitalizations that count and typically makes the differences better. What about those patients you cannot do TEER on? This is a massive calcification, as you see in the upper left of the CT scan. Well, replacement may be another option. We see that the initial burden of mortality is high. It's between 8.6 and 13% in a transapical access situation. But then over time, patients benefit because they have MR0 in the majority of cases. And there are upcoming new strategies to go transfemoral, transvenous. And this dramatically reduces further the 8 to 13% 30-day mortality load on replacement. And you see here from the first analysis, very small number, but just showing the effect. There was an all-cause mortality of 0% at 30 days, and I think this shows the direction. I'm not saying that this will stay the same. It will reach perhaps 3%, 4%, but it will be significantly lower, more than 60%, 80% lower than going transapically through the ventricular myocardium. There is an interaction of mitral with the right ventricular function. Of course, there's congestion. Please note that the relation between TAPSA and right ventricular pressure load is different to the pulmonary hypertension guidelines. So the cutoff there is 0.2, 0.3, and Becky has shown here that we are looking at 0.4 if we have severe and massive torrential regurgitation. Is it also too late here? Here you see a remodeling of a patient with a massively enlarged right heart. You see that the left heart is underfilled, and look at both entities after 1 year. There is a massive remodeling. The RA gets 50% smaller, the RV gets smaller, and the left heart fills. So cardiac output in these patients is 25% up, and I think this is much more important than to look here at the left ventricular ejection fraction, which is good in both times. But the stroke volume increases massively by treating the right heart, and we know this from Fallot. So this is the New England Journal publication from Paul Saraja and the Triluminate randomized control cohort that was negative at 1 year, but like COAPT in mortality, it was disappointing on heart failure hospitalization, but it was very, very reassuring on quality of life and also on reduction of TR. And this is the first ever randomized control trials after 40 years of surgical therapy that have never shown any benefit to the patients in 4 decades of therapy. This is the reassuring addition of a registry, 511 patients, so much more than those 300 in the randomized trial. In the treatment arm was there only 180 patients. Here you can see the real-world population of 79-year-old patients, 44% male, the only female predominant disease. You see the ejection fraction is good. You see cardiovascular mortality at 30 days, 0.8. So this is as healthy as taking a pill or a drug. So these therapies here is safe as it can be, and you see no stroke. But you see also the very good KCCQ improvement that was mentioned earlier on the right. And this is very new. This is shared. This was accepted 2 days ago in Circulation. You can see the 2-year outcome of the Triluminate initial CE study, and you can see that the improvement of TR from massive or torrential down to moderate or less, this is moderate, mild, and none, reduces your composite endpoint of heart failure hospitalization, and it shifts the curve, as you can see, to the right. So the first heart failure hospitalization in the group with still severe disease is at 50 days. The first heart failure hospitalization in the treatment group is with a good result, is at 170 days, and the curves separate over time, as you can see, and you can cut this down by half, like we've seen it in the co-op trial. There is also data on replacement, as you can see here, also reduction in TR, but there are caveats, and this is conduction disturbances, like given in red here, structural valve deterioration for replacement in the low flow field, and also severe bleeding, because these sheaths still are large. They're 1 centimeter to 1.5 centimeter, and this inflicts on bleeding. But the echocardiographic findings are incredibly good. You see TR reduction to less than 1 in 98% of the cases, all-cause death 4% at 30 days, and 7% at 1 year. So this is a lot of potential for the future. I'll quickly go with one slide only into aortic stenosis. We all know severe aortic stenosis being important. And I just want to mention 3 trials, which is the UNLOAD-TAVR trial, the ATLAS-TAVI trial, in moderate to severe disease, and you can see that you have a benefit, and now in more than 6,000 patients in treating aortic stenosis and reduced ejection fraction early enough. So don't make the point between 0.9 and 1.1 perhaps in the future, and we'll see the EXPAND-2 TAVR trial from Medtronic going into the same direction with 10-year follow-up in the protocol. So I think we'll learn a lot. So my conclusions are very short. Time is over. There is a new era of valvular heart failure. Interventional treatment of valvular disease is a promising interventional approach for improving clinical and survival outcomes. Valvular heart failure is a new treatment entity for an upcoming age-related morbidity burden of Western, Asian, and worldwide communities and cohorts. And I hope I made the point. Thank you very much for this also very narrow topic.